Surgeons are the masters of fluids because they need to be. They care for patients who cannot eat or drink for various reasons. For example, they have hemorrhaged, undergone surgery, or lost fluids from tubes, drains, or wounds. Surgeons are obligated to know how to care for these patients who put their lives in their hands. This topic might appear simple only for those who do not understand the complexities of the human body and its ability to regulate and compensate fluids. In reality, the task of managing patients' blood volume is one of the most challenging burdens surgeons face, often requiring complete control of the intake and output of fluids and electrolytes, and often in the presence of blood loss. Surgeons do not yet completely understand the physiology of shock and resuscitation, and their knowledge is superficial. Given the nature of the profession, they have studied those topics and dealt with patients who bleed and exsanguinate. Historically, wartime experience has always helped them move ahead in their knowledge of the management of fluids and how to better resuscitate. The recent wars in Iraq and Afghanistan are no exception, as we have learned much from these wars. Constant attention to and titration of fluid loss therapy is required because the human body is dynamic. The key to treatment. 44. Uploaded by current status of fluid types. Crystal is to realize what an individual patient's initial condition is and to understand that their fluid status is constantly changing. Bleeding, sepsis, neuroendocrine disturbances, and dysfunctional regulatory systems can all affect patients who are undergoing the dynamic changes of illness and healing. The correct management of blood volume is highly time dependent. If it is managed well, surgeons are afforded the chance to manage other aspects of surgery, such as nutrition, administration of antibiotics, drainage of abscesses, relief of obstruction and of incarceration, treatment of ischemia, and resection of tumors. Knowing the difference between dehydration, anemia, hemorrhage, and over-resuscitation is vital. The human body is predominantly water, which resides in the intravascular, intracellular, and interstitial or third space. Water movement between these spaces is dependent on many variables. This chapter focuses on the management of the intravascular space because it is the only space surgeons have direct access to, and managing the intravascular space is the only way to impact the other two fluid compartments. This chapter also examines historical aspects of shock, fluids, and electrolytes, not just to note interesting facts or to pay tribute to deserving physicians, but also to try to understand how. MedBooks VN. Knowledge evolved over time. Doing so is vital to understanding past changes in management, as well as to accept future changes. We are often awed at the discoveries of the past, yet also astounded by how wrong we often were and why. Certainly, in turn, future surgeons will look back at our current body of knowledge and be amazed at how little we knew and how frequently we were wrong. A consequence of not studying the past is to repeat its errors. After the historical highlights, this chapter discusses various fluids that are now used along with potential fluids under development. Finally, caring for perioperative patients is explored from a daily needs perspective. History. History is disliked by those who are in a hurry to just learn the bottom line. Learning from the past, however, is essential to know which treatments have worked and which have not. Dogma must always be challenged and questioned. Were the current treatments based on science? Studying the history of shock is important for at least 3 reasons. First, physicians and physiologists have been fascinated with blood loss out of necessity. Second, we need to assess what experiments have or have not been done. Third, we need to know more, because our current understanding of shock is elementary. Resuscitation. One of the earliest authenticated resuscitations in the medical literature is the miraculous deliverance of Anne Green, who was executed by hanging on December 14. 1650.1 Green was executed in the customary way by being turned off a ladder to hang by the neck. She hanged for half an hour, during which time some of her friends pulled with all their weight upon her legs, sometimes lifting her up and then pulling her down again with a sudden jerk, thereby the sooner to dispatch her out of her pain. Figure 4.1. When everyone thought she was dead, the body was taken down, put in a coffin, and taken to the private house of Dr. William Petty, who, by the king's orders, was allowed to perform autopsies on the bodies of all persons who had been executed. Fig 4.1, miraculous deliverance of Anne Green, who was executed in 1650. From Hughes, when the coffin was opened, Green was observed to take a breath, and a rattle was heard in her throat. Petty and his colleague, Thomas Willis, abandoned all thoughts of dissection and proceeded to revive their patient. They held her up in the coffin and then, by wrenching her teeth apart, poured hot cordial into her mouth, which caused her to cough. They rubbed and chafed her fingers, hands, arms, and feet. After a quarter of an hour of such effort, they put more cordial into her mouth. Then, after tickling her throat with a feather, she opened her eyes momentarily. At that stage, they opened a vein and bled her of 5 ounces of blood. They continued administering the cordial and rubbing her arms and legs. Next, they applied compressing bandages to her arms and legs. Heating plasters were put to her chest, and another plaster was inserted as an enema to give heat and warmth to her bowels. They then placed Green in a warm bed with another woman to lie with her to keep her warm. After 12 hours, Green began to speak. 24 hours after her revival, she was answering questions freely. At 2 days, her memory was normal, apart from her recollection of her execution and the resuscitation. Shock hemorrhagic shock has been extensively studied and written about for many centuries. Injuries, whether intentional or not, have occurred so frequently that much of the understanding of shock has been learned by surgeons taking care of the injured. What is shock? The current widely accepted definition is inadequate perfusion of tissue. However, many subtleties lie behind this statement. Nutrients for cells are required, but which nutrients are not currently well defined. Undoubtedly, the most critical nutrient is oxygen, but concentrating on just oxygenation alone probably represents very elemental thinking. Blood is highly complex and carries countless nutrients, buffers, cells, antibodies, hormones, chemicals, electrolytes, and antitoxins. Even if we think in an elemental fashion and try to optimize the perfusion of tissue, the delivery side of the equation is affected by blood volume, anemia, and cardiac output company. Moreover, the use of nutrients is affected by infection and drugs. The vascular tone plays a role as well. For example, in neurogenic shock, the sympathetic tone is lost, and in sepsis, systemic vascular resistance decreases because of a broken homeostatic process or possibly because of evolutionary factors. The term shock appears to have been first employed in 1743 in a translation of the French treatise of Henri-François Ledran regarding battlefield wounds. He used the term to designate the act of impact or collision rather than the resulting functional and physiologic damage. However, the term can be found in the book Gunshot Wounds of the Extremities, published in 1815 by Guthrie, who used it to describe physiologic instability. Humoral theories persisted until the late 19th century, but in 1830, Herman provided one of the first clear descriptions of intravenous IV fluid therapy. In response to a cholera epidemic, he attempted to rehydrate patients by injecting 6 ounces of water into the vein. In 1831, O'Shaughnessy also treated cholera patients by administering large volumes of salt solutions intravenously and published his results in Lancet. Those were the first documented attempts to replace and to maintain the extracellular internal environment or the intravascular volume. Note, however, that the treatment of cholera and dehydration is not the ideal treatment of hemorrhagic shock. In 1872, Gross defined shock as a manifestation of the rude unhinging of the machinery of life. His definition, given its accuracy and descriptiveness, has been repeatedly quoted in the literature. Theories on the cause of shock persisted through the late 19th century. Although it was unexplainable, it was often observed. George Washington Crowell concluded that the lowering of the central venous pressure in the shock state in animal experiments was due to a failure of the autonomic nervous system. Surgeons witnessed a marked change in ideas about shock between 1888 and 1918. In the late 1880s, there were no all-encompassing theories, but most surgeons accepted the generalization that shock resulted from a malfunctioning of some part of the nervous system. Such a malfunctioning has now been shown to not be the main reason, but surgeons are still perplexed by the mechanisms of hemorrhagic shock, especially regarding the complete breakdown of the circulatory system that occurs in the later stages of shock. In 1899, using contemporary advances with sphygmomanometers, Crowell proposed that a profound decline in blood pressure BP could account for all symptoms of shock. He also helped alter the way physicians diagnose shock and followed its course. Before Crowell, most surgeons relied on respiration, pulse, or a declining mental status when evaluating the condition of patients. After Crowell's first books were published, many surgeons began measuring BP. In addition to changing how surgeons thought about shock, Crowell was a part of the therapeutic revolution. His theories remained generally accepted for nearly 2 decades, predominantly in surgical circles. Crowell's work persuaded Harvey Cushing to measure BP in all operations, which in part led to the general acceptance of BP measurement in clinical medicine. Crowell also concluded that shock was not a process of dying, but rather a marshaling of the body's defenses in patients struggling to live. He later deduced that the reduced volume of circulating blood, rather than the diminished BP, was the most critical factor in shock. Crowell's theories evolved as he continued his experimentations. In 1913, he proposed the kinetic system theory. He was interested in thyroid hormone and its response to wounds, but realized that epinephrine was a key component of the response to shock. He relied on experiments by Walter B. Cannon, who found that epinephrine was released in response to pain or emotion, shifting blood from the intestines to the brain and extremities. Epinephrine release also stimulated the liver to convert glycogen to sugar for release into the circulation. Cannon argued that all the actions of epinephrine aided the animal in its effort to defend itself. Crowell incorporated Cannon's study into his theory. He proposed that impulses from the brain after injury stimulated glands to secrete their hormones, which in turn affected sweeping changes throughout the body. Crowell's kinetic system included a complex interrelationship among the brain, heart, lungs, blood vessels, muscles, thyroid gland, and liver. He also noted that if the body received too much stress, the adrenal glands would run out of epinephrine, the liver of glycogen, the thyroid of its hormone, and the brain itself of energy, accounting for autonomic changes. Once the kinetic system ran out of energy, BP would fall and the organism would go into shock. Henderson recognized the importance of decreased venous return and its effect on cardiac output and arterial pressure. His work was aided by advances in techniques that allowed careful recording of the volume curves of the ventricles. Fat embolism also led to a shock-like state, but its possible contribution was questioned because study results were difficult to reproduce. The vasomotor center and its contributions in shock were heavily studied in the early 1900s. In 1914, man noted that unilaterally innervated vessels of the tongues of dogs, ears of rabbits, and paws of kittens appeared constricted during shock, compared with contralaterally denervated vessels. Uploaded by. Battlefield experiences continued to intensify research on shock. During the World War I era, Cannon used clinical data from the war as well as data from animal experiments to examine the shock state carefully. He theorized that toxins and acidosis contributed to the previously described lowering of vascular tone. He and others then focused on acidosis and the role of alkali in preventing and prolonging shock. The adrenal gland and the effect of cortical extracts on adrenalectomized animals were a fascination during this period. Then, in the 1930s, a unique set of experiments by Blaylock 5 determined that almost all acute injuries are associated with changes in fluid and electrolyte metabolism. Such changes were primarily the result of reductions in the effective circulating blood volume. Blaylock showed that those reductions after injury could be the result of several mechanisms, box 4.1. He clearly showed that fluid loss in injured tissues was loss of extracellular fluid, ECF, that was unavailable to the intravascular space for maintaining circulation. The original concept of a third space in which fluid is sequestered and therefore unavailable to the intravascular space evolved from Blaylock's studies. Carl John Wiggers first described the concept of irreversible shock. His 1950 textbook, Physiology of Shock, represented the attitudes toward shock at that time. In an exceptionally brilliant summation, Wiggers assembled the various signs and symptoms of shock from various authors in that textbook Fig, along with his own findings. His experiments used what is now known as the Wiggers prep. In his most common experiments, he used previously splenectomized dogs and cannulated the arterial system. He took advantage of an evolving technology that allowed him to measure the pressure within the arterial system, and he studied the effects of lowering BP through blood withdrawal. After removing the dog's blood to an arbitrary set point, typically 40 millimeters Hg, he noted that their BP soon spontaneously rose as fluid was spontaneously recruited into the intravascular space. To keep the dog's BP at 40 millimeter Hg, Wiggers had to continually withdraw additional blood. During this compensated phase of shock, the dogs could use their reserves to survive. Water was recruited from the intracellular compartment as well as from the extracellular space. The body tried to maintain the vascular flow necessary to survive. However, after a certain period, he found that to keep the dog's BP at the arbitrary set point of 40 millimeter Hg, he had to reinfuse shed blood. He termed this phase uncompensated or irreversible shock. Eventually, after a period of irreversible shock, the dogs died. Box 4. The IDID model is uncumuled hemorrhage, but its main problem is that the volume of hunotapes uncontrolled by the nature of the experiment. Variability is the highest in this mod, even high. It is the most realistic computerized pressure moodles that mimic the Proots during unserial thank can be used to induce the artificiality of the pre-wire control mod Smith. And colleagues developed a hybrid model of controlled, uncontrolled hemorrhage, whereby a standardized grade V live laceration is made in swine. The swine bleed to either a specified P of fixed volume, and bleeding is controlled with packing. This removes the variability classically associated with uncontrolled hemorrhage. Fluids. How did the commonly used IV Hewids, such a normal saline, enter? Medical practice is often taken for granted, given the war body of knowledge in medicine, that they were adopted through a rigorous scientific process, but that was not the CA. Symptom, genial, and reactions. Montal state Esapati delayed responses. Normal saline has a long track record and is extremely useful, but we now know that it also can be harmful. Hanog Jacob Hamburger, in his in vitro studies of red cell lit in 1882 Inco. Lai suggested that 0.9% saline was the cation of sale in human blood. He chose 0.9% saline because it has the same. Our freezing point is human serum. This fluid is often referred to as physiologic or normal saline, but it is neither physiologic nor normal. In 1831, O'Shaughnessy described his experience in the treatment of cholera. Uterial stagnation of the monomen rumem and rapat cometum of its alization of the blood are the sariat, as cell the myrrh. Terran, hence the skin became blue, hence anal beat, no longer generated, hence the sins dye upended the black blonde art as sedevolent from the lungs and thedorfic spatum is old, as when it enters the of shock. Mus, Ashan, Scion, of part dry, cold. O'Shaughnessy wrote those words at the age of 22, having just graduated from Edinburgh Medical School. He tested his new method of infusing IV fluids on a dog and observed no ill effects. Eventually, he reported that the aim of his method was to restore blood to its natural specific gravity and to restore its deficient saline. Matters. His experience with human cholera patients taught him that the practice of bloodletting, then highly common, was good for diminishing the venous congestion, and that nitrous oxide laughing gas was not useful for oxygenation. In 1832, Robert Lewins reported that he witnessed Thomas Latta injecting extraordinary quantities of saline into veins with the immediate effects of restoring the natural current in the veins and arteries, of improving the color of the blood, and of recovering the functions of the lungs. Lewins described Latta's saline solution as consisting of 2 drachms of muriate and 2 scruples of carbonate of soda to 60 ounces of water. Later, however, Latta's solution was found to equate to having 134 MOA per liter of Na, 118 MOA per liter of Cl, and 16 MOA per liter of bicarbonate HCO3. During the next 50 years, many reports cited various recipes used to treat cholera, but none resembled 0.9% saline. In 1883, Sidney Ringer reported on the influence exerted by the constituents of the blood on the contractions of the ventricle, figure 4.3. Studying an isolated heart model from frogs, he used 0.75% saline and a blood mixture made from dried bullocks' blood. In his attempts to identify which aspect of blood caused better results, he found that a small quantity of white of egg completely obviates the changes occurring with saline solution. He concluded that the benefit of white of egg was because of the albumin or the potassium chloride. To show what worked and what did not, he described endless experiments with alterations of multiple variables. However, Ringer later published another article stating that his previously reported findings could not be repeated. Through careful study, he realized that the water used in his first article was Fig. Sidney Ringer, credited for the development of lactated Ringer solution. From basket from the New River Water by, actually not distilled water as reported, but rather tap water from the New River Water Company. It turned out that his laboratory technician, who was paid to distill the water, took shortcuts and used tap water instead. Ringer analyzed the water and found that it contained many trace minerals, figure 4.4. Through careful and diligent experimentation, he found the calcium bicarbonate, or calcium chloride, in doses even smaller than in blood, restored good contractions of the frog ventricles. The third component that he found essential to good contractions was sodium bicarbonate. Thus, the 3 ingredients that he found essential were potassium, calcium, and bicarbonate. Ringer's solution soon became ubiquitous in physiologic laboratory experiments. In the early 20th century, fluid therapy by injection under the skin hypodermoclysis and infusion into the rectum proctoclysis became routine. Hartwell and Hoggett reported its use in intestinal obstruction in dogs, laying the foundation for saline therapy in human patients with intestinal obstruction. As IV crystalloid solutions were developed, Ringer's solution was modified, most notably by pediatrician Alexis Hartman. In 1932, wanting to develop an alkalinizing solution to administer to his acidotic patients, Hartman modified Ringer's solution by adding sodium lactate. The result was lactated Ringer LR, or Hartman solution. He used sodium lactate instead of sodium bicarbonate. The conversion of lactate into sodium bicarbonate was sufficiently slow to lessen the danger posed by sodium bicarbonate, which could rapidly shift patients from compensated acidosis to uncompensated alkalosis. In 1924, Rudolf Mattis, regarded as the originator of modern fluid treatment, introduced the concept of the continued IV drip, but also warned of potential dangers of saline infusions. He stated, "Normal saline has continued to gain popularity, but the problems with metabolic derangements have been repeatedly shown but seem to have fallen on deaf ears. In healthy volunteers, modern-day experiments have shown that normal saline can cause abdominal discomfort and pain, nausea, drowsiness, and decreased mental capacity to perform complex tasks. The point is that normal saline and LR solution have been formulated for conditions other than the replacement of blood, and the reasons for the formulation are archaic. Such solutions have been useful for dehydration when they are used in relatively small volumes, 1,3 day. They are well tolerated and relatively harmless. They provide water, and the human body can tolerate the amounts of electrolytes they contain. Over the years, LR solution has attained widespread use for treatment of hemorrhagic shock. However, normal saline and LR solution are mostly permeable through. They consist of calcium 38, the vascular membrane, but they are properly retained in the vascular space after a few hours, only about 175 to 200 ml of ile in food. Sin main in the incule space. In countries other than the United States, LR solution is often returned to a Hartmann solu. In and mal saline is referred to as physiologic, sometimes even spelled flag slim. With the advances in science in the last 50 years, it is difficult to understand why bounces in resuscitation fluids have not been melee. Blood transfusions. Concern about the blood that injured patients loot. Cryle began to experiment with blood transfusions. As he stated, after many sidings, profuse hemorrhage often led to thick before the patient entered the hospital. Saline wanes, adrenaline, and precise surgical technique could batute only up to a point for the leak blood. At the turn of the 19th century, transfusions were damn med. There, we waxed and waned in popularity because of transfusion and difficulties in preventing clotting in donated blood. Through his experiments in dogs, Cryle showed that blood was interchangeable. He transfused blood without blood. Matching Alexis Corre was able to sew blood together with his angulation technique, using it to CM neck blood vessels from Perion and another for the purpose of transfusions. How Cryle fund cards technique too slow and cumbermone and who. Mans, he developed a short cannula to facilitate transfusion. By the time World War II occurred, shock was recognized, the single most common cause of nestable morbidity and mortality. At the time of the Japanese attack on Pearl Harbor on December B71941, no blood banea or effectual blood memphunion facilities were available. Manned military escations had no stacks of dried Pulu plasma. Although the wounded of that era were evacuated quickly, so a hospital, the mortality rate was well high. IV fluids of any kind were swingeally unavailable, except for a fur liters of manufactured by means of a mill in the operating mom I4 fluid, woolly administered by an old Sabiston dash and a med rubber tube, often a severe filial reaction read from. The use of that Rubing, his written documentation of resuscitations in World War. Our patients was 1 year after Pearl Harbor in December 1942. In notes from the 77th Evacuum Hospital in North Africa, Ed. Churchill stated, the wounded in action had, for the most part, others succumbed or recovered from any extinct shock mutant W then. However, later CES came to us in Thok, and some of the early cares were found to be in need of whole blood transfusion. There was plenty of reconstituted blood plasma available. However, some cases were in dire need of well blood. We had no transfusion, although such an available in the United States, no sodium citrate, no sterile distilled water, and no flood donors. The initial decision to rely on plasma, rather than on blood AP pairs, have been based in part on a view held in the office of the Surgeon General of the Army, and in part on the opinion of the civilian investigators of the National Research Council. Those civilian investigators thought that, in shock, the blood was thick, and the heart level was high. On April 8, 1943, the Sungin General stated that no blood would be sent to the combat zone. 7 months later, he again refused to send blood of because of the following. 1, his observation of overseas theaters had convinced him that plasma was adequate for resuscitation of wounded men. 2, from a logistics standpoint, it was in practice CD to make locally collected blood available further forward than general hospitals in the combat zone. And 3, shipping P was the sparse vasoconstricting drugs such as epinephrine weight, uploaded by 4 shock, electrolytes, and dated because they were thought to decrease blood flow and time perfusion as they dammed the blood in the arterial portion of the circulatory system during World War II. Out of necessity, effers to make Lottie. Transfusions available heightened and led to the institution of blood banking for transfusions. Better understanding of hip linea and inadequate circulation led so the use of plasma-faded resuscitative solution. In addition to whole blood placement, thus the treatment of traumatic shock greatly improved. The administration of whole blood was thought to be extremely effective. It was widely used. Mixing whole blood with sodium citrate in a 6:1 ratio to heighten the calcium in the blood, which pre-winted cloning worked well. However, no matter what elution was used, blow chalates or crystalloids, the blood volume seemed to increase by only a fraction of what was lost. In the Korean War era, it was recognized that mon blood had to be infined for the blood volume lot to be adequately regained. The rum fin, the need for more flood was unclear, but it was thought to be due to hemolysis, pooling of blood in Simon capillary beds, and loss of fluid into U. Considerable attention was given to cheating the feet of patients. Physiology of shock. Bleeding research and experience have taught us much about the physiology napanses to bleeding the advanced trauma lit up port ATLs. Kuhn defined as 4 classes of shock table 4.1 in general. That categorization has helped paint the physiologic responses to hemorrhagic shock, emphasizing the identification of blood for and guiding treatment. Conceptually, shock occurs at 3 anatomical areas of the cardiovascular system, F4.5%. The fine level occur at the heart-white cambiogenic abnormal. Ties can be either extrinsic tension pneumothorax, hemoditer or cardiac tamponade, or intrinsic myocardial infarction, camming pump failure, cardiac contusion or laceration, SE cardiac failure. The second level occurs at the larger medium vessel level in which hemorrhage and law of blood volume leads to DOC. The late lead occurs with the small vessels in which either neurologic dysfunction of sepsis leads to vasodilatation and maldistribution at the blood volume heading to shock. The 4 classes of shock according to the ATLS count. Problematic as they were not rigorously tested or proven in we. Table 41, ATL's classes of hemorrhagic shock. Tim, puberty, class, 15 to 30, class.RF20, admittedly arbitrarily generated. Patients often do not exhibit all of the physiologic changes described by this table, particularly those at age extremes. Due to higher water composition of their bodies, children are able to compensate with large volumes of blood loss, often exhibiting only tachycardia until they reach a tipping point where they are no longer able to compensate, at which point they have a rapid clinical decline. Elderly patients show almost an opposite physiology, as they are less equipped to compensate for blood loss and will show signs of a higher level of shock at a lower volume of blood loss. This is due to a reduced ability of cardiac compensation and fluid reserve recruitment. The problem with the signs and symptoms classically taught in ATLS classes is that, in reality, the manifestations of shock can be confusing and difficult to assess, particularly in trauma patients. For example, changes in mental status can be caused by blood loss, traumatic brain injury, TBI, pain, or illicit drugs. The same dilemma applies for respiratory rate and skin changes. are alterations in a patient's respiratory rate or skin color caused by pneumothorax, rib fracture pain, or inhalation injury. Although there are various methods that have been developed for monitoring patients in shock, BP continues to be the most clinically useful measure. When caring for a patient in shock, goals of resuscitation need to be established, remembering that baseline BP and blood volume are extremely variable and often unknown while initiating treatment. Although there is no single universally applicable endpoint of resuscitation, a combination of normalization of serum lactate, base deficit pH, and hemorrhage control, if Fig 4.5, uploaded by, applicable, are markers that can be considered along with the rest of the patient's overall clinical status. Clinical symptoms are relatively few in patients who are in class I shock, with the exception of anxiety. Is the anxiety after injury from blood loss, pain, trauma, or drugs? A heart rate higher than beats min has been used as a physical sign of bleeding, but evidence of its significance is minimal. Razel and colleagues 11 have shown that heart rate was neither sensitive nor specific in determining the need for emergent intervention. The need for packed red blood cell PRBC transfusions in the first 2 hours after an injury or the severity of the injury, heart rate was not altered by the presence of hypotension, systolic BP less than 90 millimeters Hg. In patients who are in class 2 shock, we are taught that their heart rate is increased, but as previously mentioned, this is a highly unreliable marker. Pain and mere nervousness can also increase heart rate. The change in pulse pressure, the difference between systolic and diastolic pressure, is also difficult to identify because the baseline BP of patients is not always known. The change in pulse pressure is thought to be caused by an epinephrine response constricting vessels, resulting in higher diastolic pressures. Not until patients are in class 3 shock does BP theoretically decrease. At this stage, patients have lost 30% to 40% of their blood volume for an average man weighing 75 kilograms, 168 pounds. This equates to 2L of blood loss, figure 4.6. It is helpful to remember that a can of soda or beer is 355 ml, a six-pack is 2,130 ml. Theoretically, if a patient is hypotensive from blood loss, they have lost the equivalent of a six-pack of blood. The first and most, cardiogenic shock, extrinsic, tamponade, intrinsic failure. Important key when a patient is in shock due to hemorrhage is recognizing that blood loss is the cause of their shock and identify the source of bleeding and treat it. Resuscitation occurs simultaneously as needed. Since ATLS is designed for physicians who are not surgeons, many subtleties around the physiology of a bleeding patient are missing. However, surgeons know that there are some nuances of the varied responses to injuries in both animals and humans. In the case of arterial hemorrhage, for example, animals do not necessarily manifest tachycardia as their first response when bleeding, but actually become bradycardic. It is speculated that this is a teleological mechanism, as a bradycardic response reduces cardiac output and minimizes uncontrolled exsanguination. A bradycardic response to bleeding is not consistently shown in all animals, including humans. Some evidence shows that this response, termed relative bradycardia, does occur in humans. Relative bradycardia is defined as a heart rate less than 100 beats min, while simultaneously having a systolic BP below 90 mmHg. Hg. When bleeding patients have relative bradycardia, their mortality rate is lower. Up to 44% of hypotensive patients who are not bleeding have relative bradycardia. However, this lower heart rate is only protective to a certain level, as patients with a heart rate below 60 beats min are usually more abundant. Bleeding patients with a heart rate of 60 to 90 beats min have the highest survival rate compared with patients with tachycardia, a heart rate of more than 90 beats min. The physiologic response to bleeding also subtly differs according to whether the source of bleeding is arterial or venous. Arterial bleeding is an obvious problem, but it often stops temporarily on its own. The human body has evolved to trap the blood loss in adventitial tissues, and the transected artery will spasm and thrombose. A lacerated artery can actually bleed more than a transected artery, as the spasm of the lacerated artery can enlarge the hole in the vessel. Thrombosis of the artery sometimes does not occur in transected or lacerated vessels. Also, since the arterial system does not have valves, the recorded BP can drop early, even before large volume loss has occurred. In these patients with arterial bleeding, hypotension may occur soon, but because ischemia has not yet had a chance to occur, measurements of lactate or base deficit can yield normal results. In contrast, venous bleeding is typically slower, allowing the human body time to compensate. This slower progression provides the time necessary for recruitment of water from the intracellular and interstitial spaces. This leads to large volumes of blood that, uploaded by foreshock, can be lost before hypotension ensues. Since venous or capillary bed bleeding is slower and the body has a chance to compensate, this allows for tissue ischemia to develop during the process, and thus there is time for lactate and base deficit results to be abnormal. Venous blood loss can be massive before hypotension occurs. It is generally taught that the hematocrit or hemoglobin HGB level is not reliable in predicting blood loss. This can be true in patients who have not been resuscitated, but in patients who have received crystalloids, a rapid drop in the hematocrit and hemoglobin levels can occur. Bruns and Associates 13 have shown that the hemoglobin level can be low within the first 30 minutes after patients arrive at trauma centers. Therefore, high or normal hemoglobin levels do not rule out significant bleeding. But a low hemoglobin level, because it occurs rapidly, generally reflects severe blood loss. The lack of good indicators to distinguish which patients are bleeding has led many investigators to examine heart rate variability or complexity as a potential new vital sign. Many clinical studies have shown that heart rate variability or complexity is associated with poor outcome. Heart rate variability or complexity would have to be calculated using software with a resulting index on which clinicians would have to rely. This information would not be available by merely examining patients. Another issue with heart rate variability or complexity is that the exact physiologic mechanism for its association with poor outcome has yet to be elucidated. 14. This new vital sign may be programmable into currently used monitors, but its usefulness is yet to be confirmed. Hypotension has been traditionally set arbitrarily at 90 mmHg and below, but this level can be variable from patient to patient, especially depending on age. Eastridge and co-workers 15 have suggested that hypotension be redefined as below 110 mmHg. In 2008, Bruns and colleagues 16 confirmed the concept, showing that a pre-hospital BP below 110 mmHg was associated with a sharp increase in mortality, and that 15% of patients with BP below 110 mmHg would eventually die in the hospital. As a result, they recommended redefining pre-hospital trauma triage criteria. In older patients, normal vital signs may miss occult hypoperfusion, as geriatric patients often have increased lactate and base deficit levels. Shock index, since heart rate and systolic BP individually are not accurate at identifying hemorrhagic shock, and because the traditionally taught combination of tachycardia and decreased systolic BP does not always occur. Together, the shock index psi, which uses these two variables together, was developed. Psi is defined as heart rate divided by systolic BP. It has been shown to be a better marker for assessing severity of shock than heart rate and BP alone. It has utility not only in trauma patients often in hemorrhagic shock, but also in patients who are in shock from other causes such as sepsis, obstetrics, myocardial infarction, stroke, and other acute illnesses. In the trauma population, psi has been shown to be more useful than heart rate and BP alone, and it has also been shown to be of benefit specifically in the pediatric and geriatric populations. It has been correlated with need for interventions such as blood transfusion and invasive procedures, including operations. Psi is known as a hemodynamic stability indicator. However, psi does not consider the diastolic BP, and thus a modified psi MSI was created. MSI is defined as heart rate divided by mean arterial pressure. As MSI rises, this indicates a low stroke volume and low systemic vascular resistance, a sign of hypodynamic circulation. In contrast, low MSI indicates a hyperdynamic state. MSI has been considered a better marker than SI for mortality rate prediction, although psi or MedBook's VN 52 section I surgical basic principles. MSI is better than heart rate and systolic BP alone. The combination of one of these variables with heart rate and systolic BP will undoubtedly be more useful. There are additional studies showing that more complex calculations with more variables are more useful than simpler ones. For example, taking into account the age, mechanism of injury, Glasgow Coma Scale, GCS score, lactate levels, hemoglobin levels, and other physiologic parameters will result in statistically better prediction than with one individual vital sign. It is intuitive that the addition of variables would be more predictive of outcome. That is why the presence of an experienced surgeon is critical. In a few seconds, the astute clinician will quickly consider multiple variables, including gender, age, GCS score, mechanism of injury, and other parameters. Whereas SI and MSI are statistically more accurate than one individual parameter, there's no substitute for the experienced clinician at the bedside. This may be the reason that psi and MSI have not been widely adopted. Lactate and base deficit lactate has stood the test of time as an associated marker of injury and possibly ischemia. However, new data question the etiology and role of lactate. The emerging information is confusing. It suggests that we may not understand lactate for what it truly implies. Lactate has long been thought to be a byproduct of anaerobic metabolism and is routinely perceived to be an end-waste product that is completely unfavorable. Physiologists are now questioning this paradigm and have found that lactate behaves more advantageously than not. An analogy would be that firefighters are associated with fires, but that does not mean that firefighters are bad, nor does it mean that they cause the fires. Research has shown that lactate increases in muscle and blood during exercise. It is at its highest level at or just after exhaustion, which led to the assumption that lactate was a waste product. In addition, we also know that lactic acid appears in response to muscle contraction and continues in the absence of oxygen. Furthermore, accumulated lactate disappears when an adequate supply of oxygen is present in tissues. Recent evidence indicates that lactate is an active metabolite capable of moving between cells, tissues, and organs where it may be oxidized as fuel or reconverted to form pyruvate or glucose. It now appears that increased lactate production and concentration as a result of anoxia or dysoxia are often the exception rather than the rule. Lactate seems to be a shuttle for energy. The lactate shuttle is now the subject of much debate. The end product of glycolysis is pyruvic acid. Lack of oxygen is thought to convert pyruvate into lactate. However, lactate formation may allow carbohydrate metabolism to continue through glycolysis. It is postulated that lactate is transferred from its site of production in the cytosol to neighboring cells and to a variety of organs, e.g. heart, liver, and kidney, where its oxidation and continued metabolism can occur. Lactate is also being studied as a pseudohormone, as it seems to regulate the cellular redox state through exchange and conversion into pyruvate, and through its effects on the ratio of nicotinamide adenine dinucleotide to nicotinamide adenine dinucleotide reduced, the NADH ratio. It is released into the systemic circulation and taken up by distal tissues and organs, where it also affects the redox state in those cells. Further evidence has shown that it affects wound regeneration with promotion of increased collagen deposition and neovascularization. Lactate may also induce vasodilatation and catecholamine release and stimulate fat and carbohydrate oxidation. Lactate levels in blood are highly dependent on the equilibrium between production and elimination from the bloodstream. Uploaded by the liver is predominantly responsible for clearing lactate, and liver disease affects lactate levels. Lactate was always thought to be produced from anaerobic tissues, but it now seems that a variety of tissue beds that are not undergoing anaerobic metabolism produce lactate when they are signaled with distress. In canine muscle, lactate is produced by moderate intensity exercise when the oxygen supply is ample. A high adrenergic stimulus also causes a rise in lactate as the body prepares for or responds to stress. A study of climbers of Mount Everest showed that the resting PO2 on the summit was about 2008 mmHg and decreased even more during exercise. The blood lactate level in those climbers was essentially the same as at sea level, even though they were in a state of hypoxia. These facts lead us to question what we believed we knew about lactate and its true role. In humans, lactate may be the preferred fuel in the brain and heart. In these tissues, infused lactate is used before glucose at rest and during exercise. Since lactate is glucose sparing, it allows glucose and glycogen levels to be maintained, in addition to lactates being preferred in the brain. Evidence seems to indicate that lactate is protective to brain tissues in TBI and acts as fuel during exercise for the brain. The level of lactate, whether it is a waste product or a source of energy, seems to signify tissue distress, whether it is from anaerobic conditions or other factors. During times of stress, there is a release of epinephrine and other catecholamines, which also causes a release of lactate. Base deficit, a measure of the number of millimoles of base required to correct the pH of a liter of whole blood to 7.4, seems to correlate well with lactate level, at least in the first 24 hours after a physiologic insult. Rutherford, in 1992, showed that a base deficit of 8 was associated with a 25% mortality rate in patients older than 55 years without a head injury, or in patients younger than 55 years with a head injury. When base deficit remains elevated, most clinicians believe that it is an indication of ongoing shock. One problem with base deficit is that it is commonly influenced by the chloride in various resuscitation fluids, resulting in a hyperchloremic non-gap acidosis. In patients with renal failure, base deficit can also be a poor predictor of outcome. In the acute stage of renal failure, a base deficit of less than 6 mmol is associated with poor outcome. With the use of hypertonic saline HDS, which has 3 to 8 times the sodium chloride concentration of normal saline, the hyperchloremic acidosis has been shown to be relatively harmless. However, when HDS is used, base deficit should be interpreted with caution. Compensatory mechanisms: when shock occurs, blood flow is diverted from less critical to more critical tissues. The earliest compensatory mechanism in response to a decrease in intravascular volume is an increase in sympathetic activity. Such an increase is mediated by pressure receptors or baroreceptors in the aortic arch, atria, and carotid bodies. A decrease in pressure inhibits parasympathetic discharge, while norepinephrine and epinephrine are liberated and cause adrenergic receptors in the myocardium and vascular smooth muscle to be activated. Heart rate, contractility, and peripheral vascular resistance are increased, resulting in increased BP. However, the various tissue beds are not affected equally. Blood is shunted from less critical organs, e.g. skin, skeletal muscle, and splanchnic circulation, to more critical organs, e.g. brain, liver, and kidneys. The juxtaglomerular apparatus in the kidney, in response to the vasoconstriction and decrease in blood flow, produces the enzyme renin, which leads to the generation of angiotensin 1, the angiotensin converting enzyme located on the endothelial cells of Medbooks VN. The pulmonary arteries converts angiotensin 1 to angiotensin 2. In turn, angiotensin 2 stimulates an increased sympathetic drive at the level of the nerve terminal by releasing hormones from the adrenal medulla. In response, the adrenal medulla affects intravascular volume during shock by secreting catechol hormones, epinephrine, norepinephrine, and dopamine, which are all produced from phenylalanine and tyrosine. They are called catecholamines because they contain a catechol group derived from the amino acid tyrosine. The release of catecholamines is thought to be responsible for the elevated glucose level in hemorrhagic shock. Although the role of glucose elevation in hemorrhagic shock is not fully understood, it does not seem to affect outcome. Cortisol, also released from the adrenal cortex, plays a major role in fluid equilibrium. In the adrenal cortex, the zona glomerulosa produces aldosterone in response to stimulation by angiotensin II. Aldosterone is a mineralocorticoid that modulates renal function by increasing recovery of sodium and excretion of potassium. Angiotensin II also causes the reabsorption of sodium through a direct action on the renal tubules. Sodium is the primary osmotic ion in the human body in the regulation of water balance, with the reabsorption of sodium leading to the reabsorption of water, which subsequently leads to intravascular volume expansion in response to shock. One problem is that the release of these hormones is not infinite, thus the supply can be exhausted in a state of ongoing shock. This regulation of intravascular fluid status is further affected by the carotid baroreceptors and the atrial natriuretic peptides. Signals are sent to the supraoptic and paraventricular nuclei in the brain. Antidiuretic hormone ADH is released from the pituitary, causing retention of free water at the level of the kidney. Simultaneously, volume is recruited from the extravascular and cellular spaces. A shift of water occurs as hydrostatic pressures fall in the intravascular compartment. At the capillary level, hydrostatic pressures also are reduced because the precapillary sphincters are vasoconstricted more than the postcapillary sphincters. Lethal triad. The lethal triad of acidosis, hypothermia, and coagulopathy is common in resuscitated patients who are bleeding or in shock from various factors. Our basic understanding is that inadequate tissue perfusion results in acidosis caused by lactate production. In the shock state, the delivery of nutrients to the cells is thought to be inadequate, leading to a decrease in the body's main energy storage molecule, adenosine triphosphate ATP. The human body relies on ATP production to maintain homeostatic temperatures, like all homeothermic warm-blooded animals do. Thus, if ATP production is inadequate to maintain body temperature, the body will trend toward the ambient temperature. For most human patients, this is 22 degrees Celsius, 72 degrees Fahrenheit, the temperature inside typical hospitals. The resulting hypothermia and acidosis then affect the efficiency of enzymes, which work best at 37 degrees Celsius and a pH of 7.4. For surgeons, the critical issue with hypothermia is the coagulation cascade dependence on enzymes that are affected by hypothermia. If enzymes are not functioning optimally due to hypothermia, coagulopathy worsens, which can contribute to uncontrolled bleeding from injuries or the surgery itself. Further bleeding continues to fuel the triad. The optimal method to break the vicious circle of death is to stop the bleeding and the causes of hypothermia. In most typical scenarios, hypothermia is not spontaneous from ischemia, but is induced because of use of room temperature fluid or cold blood products. Uploaded by for shock, electrolytes, and fluid. 53. Acidosis bleeding causes a host of responses. During the resuscitative phase, the lethal triad, acidosis, hypothermia, and coagulopathy is frequent in severely bleeding patients, most likely because of two major factors. First, decreased perfusion causes lactic acidosis and consumptive coagulopathy. Second, room temperature and large volume fluids lead to worsening hypothermia and dilutional coagulopathy, creating a resuscitation injury. Some believe that the acidotic state is not necessarily undesirable because the body tolerates acidosis better than alkalosis. Oxygen is more easily offloaded from hemoglobin in the acidotic environment. Basic scientists who try to preserve tissue ex vivo find that cells live longer in an acidotic environment. Correcting acidosis with sodium bicarbonate has classically been avoided as it is treating a laboratory value or symptom. The focus should be to correct the cause of the acidosis. Treating the pH alone has shown no benefit, but it can lead to complacency. It is also argued that rapidly injecting sodium bicarbonate can worsen intracellular acidosis from the diffusion of the converted CO2 into the cells. The best fundamental approach to metabolic acidosis from shock is to treat the underlying cause of shock. In the surgeon's case, this is due to blood loss or ischemic tissue. However, some clinicians believe that treating the pH has advantages because the enzymes necessary for clotting function better at an optimal temperature and optimal pH. Coagulopathy can contribute to uncontrolled bleeding, so some have recommended treating acidosis with bicarbonate infusion for patients in dire scenarios. Treating acidosis with sodium bicarbonate may have a benefit in an unintended and unrecognized way. Rapid infusion of bicarbonate is usually accompanied by a rise in BP in hypotensive patients. This rise is usually attributed to correcting the pH. However, sodium bicarbonate in most urgent scenarios is given in ampules. The 50 ml ampule of sodium bicarbonate has 1 AQML in essence, similar to giving a hypertonic concentration of sodium, which quickly draws fluid into the vascular space. Given its high sodium concentration, a 50% ml bolus of sodium bicarbonate has physiologic results similar to 325 ml of normal saline or 385 ml of LR solution. Essentially, it is like giving small doses of HTS. Sodium bicarbonate quickly increases CO2 levels by its conversion in the liver, so if the minute ventilation is not increased, respiratory acidosis can result. Thiamtromethamine trishydroxymethyl aminomethane is a biologically inert amino alcohol of low toxicity that buffers CO2 and acids. It is sodium-free and limits the generation of CO2 in the process of buffering. At 37 degrees Celsius, the pKa of thiam is 7.8, making it a more effective buffer than sodium bicarbonate in the physiologic range of blood pH. In vivo, thiam supplements the buffering capacity of the blood bicarbonate system by generating sodium bicarbonate and decreasing the partial pressure of CO2. It rapidly distributes to the extracellular space and slowly penetrates the intracellular space, except in the case of erythrocytes and hepatocytes, and it is excreted by the kidney. Unlike sodium bicarbonate, which requires an open system to eliminate CO2 to exert its buffering effect, thiam is effective in a closed or semi-closed system, and it maintains its buffering ability during hypothermia. Thiam acetate 0.3 millions, pH 8.6, is well tolerated, does not cause tissue or venous irritation, and is the only formulation available in the United States. Thiam may induce respiratory depression and hypoglycemia, which may require ventilatory assistance and the administration of glucose. Medbooks VN, Section Surgical Basic Principles. The initial loading dose of thiam, 0.3 millions, for the treatment of acidemia may be estimated as follows. Thiam in miles of 0,3 solution equal to lean body weight in kilogram of base deficit on millimoles per liter. The maximal daily due in 15 minutes, kilogram day for an adult 5L, 3-man elution in a patient weighing 70L. It is indicated in the treatment of respiratory failure factor. Respiratory dye, the symptomatic ARDS and infant respiratory dye syndrome, and has been associated with the use of hypothermia and permissive encapnia, cold hypoventilation. Other indications are diabetic and unal acidosis, salicylate and barbiturate intoxication, and increased intracranial picure, HP, association with brain trauma. It is used in complegic molutions and during liver transplantation. Despite these attributes, thiam has not been documented locally to be more efficacious than sodium bicarbonate. Hypothermia. Hypothermia can be both beneficial and detrimental. A funda. Montal Coolidge of hypothermia is AF vital importance in the case of surgical patients. The beneficial aspects of hypothermia, mainly a result of decreased metabodian injury, ran and often lead circadian autoconstriction and decreasing inflammasyon through decreased metabolism. This concept of cooling slow metabolism is also the rationale behind ooning hypothermia. To decrease ischemia during card transplant, pediatric, and neurologic surgery, Alan, amputated extremities are had before implantation. Cold water mat drowning victims have higher nervival rate. Thanks to preservation of the brain and other vital organ, the Advanced Life Subtank Fuse of the International Lisbon Committee of Resuscitation now recommends cooling to 32 degrees Celsius, 34 degrees Celsius, 12 to 24 hours of unconscious adults who have spontaneous circulation after of hospital cardiac caused by calar fibrillation-induced hypothermia is vastly differ from spontaneous hypothermia, which is typically from shock, inadequate tissue perfusion, or cold fluid infusion. Medical or accidental hypothermia is vastly different from mama aniside hypothermia, table 4.2. The survival rates after C-dental hypothermia range from about 12% on 19th. The average temperature drop is to about 30 degrees Celsius. Range 13.7 C to 350 C. That lowest recorded temperature in survivor of accidental hypothermia, 137 C56 Fahrenheit, was in an extreme set in Norway. She was trapped under the ice and eventually fully recovered logically. The data in patients with trauma-associated hypothermia differ their survival rate fairly dramatically with their core TM temperature, reaching 10% mortality when it reaches 32 degrees Celsius at any paint, whether it is in the emergency department, operating room, or intensive care unit, ICU. In trauma patients, hypothemus is due to shock and is thought to perpetuate male bleeding because of the associated coagulopathy. Trauma patients with a postoperative care temperature below 35 degrees Celsius have a 4-fold increase in death. Below 33 degrees Celsius, a 7-fold increase in death. Hypothermic trauma patients tend to. Table 4.2, classification of hypothermia. Trauma accidental. Minus 34 degrees Celsius, 15 to 3, 17 to 297, a Medunin semi, minus 52 degrees Celsius. Uploaded by Hemorrhagi injured, older and Hall, increased blood loss. Inquired increased months of transfusions. Surprisingly, in a study using the National Trauma Database, Shaw and colleagues showed that hypothermia and associated poor outcome were botulated to the state of shock. It was privy. Usly taught that cure temperature below 32 was uniformly fatal in trauma patients who have the additional insult, time, injury, and bleeding. However, a small number of trauma patients have now survived, despite a recorded coat temperature below 32 degrees Celsius. Billman and co-workers demonstrated that hypothermia was cited with most severe injuries, bleeding, and a higher rate of multiple organ dysfunction in the ICU, but not with death and multivariate analysis. They understand hypothermia We have to remember that L-mans are homeothermic, warm-blooded animals, in contrast poikilothermics, cold-blooded animals, such as rakes and fish. To maintain a body temperature of 37 degrees Celsius, our hypothalamus, a variety of mechanisms to tightly control core body temperature. We need oxygen as the key ingredient or FUD to generate her in the mitochondria in the form of ATP when ATP production is. Below its Wathold, one of the right effects is the lowering. Usly temperature, the ambient temperature, which typically is less than con body temperature in contrast during exercise. We use multi-oxygen as more ATP is required, and we produce cheat in an attempt to modulate core temperature, WA pempiring to the cooling proper met AF evaporation hypothermia, although potentially beneficial, is detrimental in trauma patients, mainly because it can coagulopathy. Cold affects the nagulation call by decreasing enzyme activity, enhancing hilarinylytic activity, and using platelet dysfunction. Platelets are affected by the inhibition of thromboxane by production, resulting in decreased aggregation. A heparin-like substance is released, causing diffuse intracalcular coagulation like windmine, Hageman factor, and thromboplastin are some of the enzymes most affected. Even a drop in core temperature of just a few degrees result in 40% inefficiency in some of the enzyme. Here affects the coagulation cascade so much that when blood is drawn in CLD patients and sent to the laboratory, the sample is heated to 37 degrees Celsius, became a 1 or 2 degrees of cold delays clotting, and renders 10 results inaccurate. Thus, in a cold and coagulopathic patient, if the coagulation profile obtained from the laboratory shows an abnormality, the result represents the level of coagulopathy if the patient, and not just the sample, had been warm. 37. Therefore, a cold parent is always more nagulopathic than indicated by the coagulation ghoul of mammocoagulation. Profile does necessarily represent what is going in the body. Here, next makud in calories. 1 calorie is the amount of enjait required to raise the temperature of ml of water, which has high definition, a specific heat of 1. It takes 1 kilocalorie to raise the temperature of IL of water by 1 Celsius if an average man weighed 75 kilograms consisted of pure water. It would take 75 kilocalories to raise his temperature by IC. However, we are not made of pure weight, and blood had a specific heat coefficient of 0.872. The human body as a while has a specific heat efficient of 0.83 there free. Acmally takes 62.2, 5 kilocalories, 75 kilograms, 0.83 to raise body temperature by IIC. If patient were to lose 62.2, 5 kilocalories, body temperature would drop by C. This basic seance is important in choosing methods to root and harm to rat hypothermia or hyperthermia. It allows one to compare the efficacy of one method with another. The normal basal metabolic hair generation is about 70% HR. Shivering can increase this to 250 kilocalories, HR, heart feed, and the body by contact conducting as in a frying pan. Medbooks in, and jacuzzi. Air or convection as in an oven and sauna, radiation and evaporation. Convection is an extremely inefficient way to transfer heat as the air molecules are so far apart compared with liquids and solids. Conduction and radiation are the most efficient ways to transfer heat. However, heating the patient with radiation is fraught with inconsistencies and technical challenges, and thus it is difficult to apply clinically. So we are left with conduction to transfer energy efficiently. Warming or cooling through manipulation of the temperature of IV fluids is useful as it uses conduction to transfer heat. Although IV fluids can be warmed, the U.S. Food and Drug Administration, FDA, allows fluid warmers to be set at a maximum of 40 degrees Celsius. Therefore, the differential between a cold trauma patient 34 degrees Celsius and warm fluid is only 6 degrees Celsius. Thus, 1 L of warm fluids can transfer only 6 kilocalories to the patient. As previously calculated, one needs about 62 kilocalories to raise the core temperature by 1 degree Celsius. Therefore, we need 10.4 L of warm fluids to raise the core temperature by 1 degree Celsius to 35 degrees Celsius. Once that has been achieved, the differential is now only 5 degrees Celsius between the patient and the warm fluid, so it actually takes 12.5 L of warm fluids to raise the patient from 35 degrees Celsius to 36 degrees Celsius. A cold patient at 32 degrees Celsius needs to be given 311 kilocalories, 75 kilograms, 0.83 to be warmed to 37 degrees Celsius. Note that a liter of fluid must be given at the highest rate possible because if the infusion rate is slow, it cools to room temperature as the IV line is exposed to ambient room temperature. To avoid IV line cooling, devices that warm fluids up to the point of insertion into the body should be used. Warming of patients by infusion of warm fluids is difficult, but fluid warmers are still critically important. The main reason to warm fluids is to prevent patients from being cooled further. Cold fluids can cool patients quickly. The fluids that are typically infused are either room temperature 22 degrees Celsius or 4 degrees Celsius if the fluids were refrigerated. The internal temperature of a refrigerator is 4 degrees Celsius, and this is where PRBCs are stored. Therefore, it takes 5 L of 22 degrees Celsius fluid or 2 L of cold blood products to cool a patient by 1 degree Celsius. Again, The main reason for using fluid warmers is not necessarily to warm patients, but to prevent cooling them during resuscitation. Rewarming techniques are classified as passive or active. Active warming is further classified as external or internal, Table 4.3. Passive warming involves preventing heat loss. An example of passive warming is drying the patient to minimize evaporative cooling, giving warm fluids to prevent cooling, or covering the patient so that the ambient air temperature immediately around the patient can be higher than the room temperature. Covering the patient's head helps reduce a tremendous amount of heat loss. Aluminum-lined head covers are preferred. They reflect back the heat that is normally lost through the scalp. Warming of the room technically. Table 4.3, classification of warming techniques. Passive, active, external, active, internal. Dry the patient bare. Hug or warm fluids. Warm fluids. Heated. Warmers, heat ventilator. Warm blankets and lamps. Cavity lavage, chest tube, sheets, abdomen, bladder provide head covers, radiant warmers. Continuous arterial or venous rewarming. Warm the room clinitron bed, full or partial bypass. Uploaded by Foreshock, Electrolytes, and Fluid 55. Helps reduce the heat loss gradient, but the surgical staff is usually unable to work in a humidified room of 37 degrees Celsius. Preventing evaporative heat loss also includes closing an open body cavity, such as the chest or abdomen. The most important way to prevent heat loss is to treat hemorrhagic shock by controlling bleeding. Once shock has been treated, metabolism will heat the patient from his or her core. This point cannot be overemphasized. Active warming is the act of transferring calories to the patient, either externally through the skin or internally. Skin and fat are designed to be highly efficient in preventing heat transfer. Whereas the fat is insulating against loss of heat, it is also the reason that transfer of heat past the skin is difficult. Active external warming is thus inefficient because of our built-in insulation compared with internal warming. The first and most important step for active rewarming is to remove any wet clothes or bedding that is present and dry the patient prior to starting any active warming technique. Without this step, the efficiency of all methods will drop dramatically, and the importance of this step cannot be overstated. External active warming with forced air heating, such as with bear hugger temperature management therapy, Arizant Healthcare Inc., Eden Prairie, Minnesota, is technically classified as active warming. But since air is a terribly inefficient medium, so few calories are provided to patients. Forced air heating increases only the patient's ambient temperature, but it can actually cool the patient initially because it increases evaporative heat loss if the patient is wet from blood, fluids, clothes, or sweat. Warming the skin may feel good to the patient and the surgeon, but it actually decreases shivering, a highly efficient method of internal warming that tricks the thermoregulatory nerve input on the skin. Because forced air heating uses convection, the actual amount of active warming is estimated to be only 10 kilocalories, HR. Active external warming is more efficiently performed by placing patients on heating pads, which use conduction to transfer heat. Beds are available that can warm patients faster, such as the Clindian Atron bed, Hill-Rom, Batesville Inn, which uses heated air fluidized beads. Such beds are not practical in the operating room, but are applicable in the ICU. Another option is the use of heating pads, which use heated water for countercurrent heat exchange. These can be placed under the patient during surgery and can be effective in minimizing mild hypothermia. The number of kilocalories per hour depends on the extent of dilatation or vasoconstriction of the blood vessels in the skin. This countercurrent heat exchange system can also be used to cool the patient if necessary. The best method to warm patients is to deliver calories internally, Table 4.4. Heating the air used for ventilators is technically a form of internal active warming, but again, is an inefficient method as this transfers heat via convection. The surface area of the lungs is massive, but the energy is mainly transferred through Table 4.4 calories delivered by active warming. Method, KCal-HR, airway from vent 9 overhead radiant warmers, 17 heating blankets, 20 convective warmers, 15, 26 body cavity lavages, 35 continuous arteriovenous rewarming, 92, 140 cardiopulmonary bypass, 710. Medbooks VN. 56 section, 1 surgical basic principles. Humidified water droplets, mostly by convection and not conduction. The amount of heat transferred through warmed humidified air is also minimal by comparison to methods that use conduction. One method by which this can be done is the lavage of warm fluids into body cavities via nasogastric tubes, Foley catheters, chest tubes, or lavage of the peritoneal cavity. If gastric lavage is desired, one method is continuous lavage by infusion of warm fluids through the sump port while the fluid is sucked out of the main tube. Instruments to warm the hand through conduction show much promise but are not yet readily available. A method that can actively rewarm a patient and also assist in the treatment of shock is extracorporeal membrane oxygenation, ECMO. With ECMO, the patient's blood is pumped through an artificial lung and then back into the bloodstream, which can support either a failing pulmonary or cardiac system. Along with oxygenation in the artificial lung, the blood can also be warmed and then returned to the patient. Recent literature also shows promise in using ECMO for rewarming after accidental hypothermia through case reports and cost-effectiveness analysis 266 and 27. Cardiopulmonary bypass can also be used as it delivers heated blood at a rate of more than 5 Lmin to every place in the body where there are capillaries. If full cardiopulmonary bypass is not available or not desired, alternatives include continuous venous or arterial rewarming. Venous rewarming can also be accomplished using the roller pump of a dialysis machine, which is often more available to the average surgeon. A prospective study showed arterial venous rewarming to be highly effective. It can warm patients to 37 degrees Celsius in about 39 minutes compared with an average warming time of 3.2 hours with standard techniques. Special Gentilello arterial warming catheters are inserted into the femoral artery, and a second line is inserted into the opposite femoral vein. The pressure from the artery produces flow, which is then directed to a fluid warmer and back into the vein. This method depends highly on the patient's BP, as flow is directly related to BP. There are also commercially available central line catheters that directly heat the blood. A countercurrent exchange system heats the tip of the catheter with warmed fluids, and as blood passes over this warmed catheter, heat is directly transferred. During recent decades, with the changes in resuscitation methods, the incidence of hypothermia has decreased. Dilutional coagulopathy also occurs less frequently as the volume of crystalloids has been minimized and particular attention has been paid to ensure that all resuscitation fluids and blood are warmed before infusion. Coagulopathy in surgical patients is multifactorial. In addition to acidosis and hypothermia, the other usual cause of coagulopathy is decreased clotting factors. This decrease can be caused by consumption from the innate attempt to stop bleeding, dilution from infused fluids devoid of clotting factors, and genetic hemophilia factors. Coagulopathy often needs to be corrected. The most commonly used tests for coagulopathy are prothrombin time, partial thromboplastin time, and international normalized ratio. However, these tests have been shown to be inaccurate in detecting coagulopathy in surgical patients. One of the major reasons is that coagulopathy is a dynamic state that evolves through different stages of hypocoagulability, hypercoagulability, and fibrinolysis. The traditional tests of blood clotting lack the ability to detect the evolution of coagulopathy through these stages, as they only depict the coagulation state at a snapshot in time. Moreover, the traditional tests are performed at normal pH and temperature, so uploaded by. They do not consider the effects of hypothermia and acidosis on coagulation. These traditional tests are also performed on serum and not on whole blood, and do not have the ability to measure the interaction of coagulation factors and platelets. More recently, thromboelastography, TAG, and rotational thromboelastometry have emerged as dynamic measures of coagulation that provide a more sensitive and accurate measure of the coagulation changes seen in surgical patients. TAG and thromboelastometry are based on similar principles of detecting clot strength, which is the final product of the coagulation cascade. They're also performed on whole blood, so they consider the functional interaction of coagulation factors and platelets. TAG parameters include R time, reaction time, alpha angle, and MA, maximum amplitude. The R time reflects the latent time until fibrin formation begins. An increase in this time may result from either decreased activity or deficiencies of coagulation factors, whereas a decrease in R time reflects a hypercoagulable state. The steepness of the alpha angle reflects the rate of fibrin formation and cross-linking, with a sharper angle indicating increased fibrin formation and a flatter angle indicating slower formation. The measure of clot strength is MA, which reflects clot elasticity. The value of MA is a measure of the strength of interaction between the coagulation factors, fibrin, and platelets. Qualitative or quantitative defects in either of these would result in decreased MA. TAG provides the additional ability to measure the fibrinolytic arm of the coagulation cascade. Ly30 and Ly60 indices provide a measure of the fibrinolysis rate by calculating the decrease in clot strength at 30 and 60 minutes respectively. A large lysis index reflects rapid fibrinolysis and may help guide the use of antifibrinolytic therapy, which has been shown to reduce mortality if it is used within 3 hours of injury in these patients. Components of a TAG can help guide treatment of a bleeding patient, as they can give the surgeon information regarding what part of the clotting cascade is defective. These tests are routinely used in cardiac surgery and are becoming more popular in trauma and liver transplant surgery in the form of point-of-care testing, but they are not widely available in most hospitals. Figure 4.7. The methods to define and to treat coagulopathy are still varied. As discussed earlier, stopping the lethal triad is the most important step to stop the vicious cycle of hemorrhage. Prothrombin complex concentrate, PCC, has become popular for the treatment of surgical coagulopathy. PCC actually has many factors 2, 7-IXX in it, including variable amounts of factor VIA, depending on the brand of PCC used. For patients taking warfarin, PCC is the recommended treatment of choice, as this treatment replaces the factors lost with warfarin. This is of particular benefit in elderly patients with TBI, in whom treatment with fresh frozen plasma, FFP, can potentially be a problem if the patient has comorbid cardiac. Alpha angle, RK coagulation, Fig 4.7, Ma fibrinolysis, coagulation and fibrinolysis testing. Ly30, Medbooks VN, disease, and could induce cardiac heart failure from volume overload. Additional benefit of using PCC that the time to reversal of coagulopathy is shorter than when FFP is used. The use of blood-based component therapy is paramount in treating coagulopathy. Later, evolution of modem resuscitation, PCC, has been snubbled as trauma patients at risk for bleeding with promising LT, but the studies are not randomized and require further confirmation. If there were a drug that would stop or reduce bleeding, treat coagulopathy at a low COM, and not cause serious complications would be landmark contribution to medicine. Again, the problem is that current candidates are expensive, and the adverse even from administering such a drug are still not fully elucidated. Another ingot of the coagulation cascade for medication is modulating the fibrinolytic pathways. Tranexamic acid, TXA, is a synthetic analog of the amino acid lysine and is an antifibrinolytic medication that competitively inhibits the activation of plasminogen deplamin. It prevents degradation of fibrin, which is a protein that forms the framework at blood clots. TXA has a boo. Enter the antifibrinolytic activity of an older umlog, aminocaproic acid. It is used to trot AR to prevent blood. Less during cardiac, liver, vascular, and orthopedic surgical procalor. Seems that topical TXA is effective and safe after idle. Knee and hip replacement surgery, along with mucopharyngeal bleeding in patients who are thrombocytopenic during bleeding, and the need for blood transfusion studies have shown similar results in children undergoing craniofacial surgery, spinal surgery, and others. It is even used for heavy mental bleeding in anal tablet forms and in dentistry at a 5% mouthwash. It has been advocated for use in trauma. It seems to be effective in reducing relieving SPAMU intrarenal being. A small, delended, placebo-controlled, randomized study, AF 238 patients, showed reduction in progression of intracranial bleeding after trauma, but because of the small sample size, it was not statistic. Cali significant text aimed to at primary fibrinolysis, which is integral in the pathogenesis of the acute coagulopathy of trauma. The clinical randomization of an antifibrinolytic in Signify CM hemorrhage crash -2 mal, a multi-center randomized called civilian trial of 20,211 patines, showed that TXA-induced all-came mortality, venous placebo, 14.5% x 16%. The risk of death canned by bleeding was also reduced, 4.9% versus 57%. Crash 2-al agreed that TXA was less effective and could even be harmful if Marmot was delayed more than 3 hours after admission. This was confirmed in the retrospective military application of tranexamic acid in TROM's emergency resuscitation matter UD and rapidly incorporated into military practice guidelines. And subsequently, for civilians worldwide, the PED track study demandated that in children needed at a military Lumpatol in Afghanistan. TXA administration, 66 of the 766 children, was independently acaciated with decreased mortality and improved pneumologic and pulmonary outcome. Although the CRASH 2 trial was a randomized study with placebo, the CRI-ICX of the study point out that it was performed in 270 hospitals in 40 countries, and the large sample size MUI result in a beta error, meaning that the study was statistically significant because of the large number of patients in the study. But the small differences in outcome may not necessarily be clinically relevant. The absolute RIT reduction was approximately 15%, with an estimated EUM bet needed to eat of 68. The CRASH -3 mal is currently being conducted to assess the effect of TXA on risk of death or disability. In patients with TB, the key will be doing timing and patient selection. The drug is attractive because it is inexpensive, $5.70 per dose, and easy use with seemingly minimal side effects. Uploaded by Foreshock, Electrolytes, and Fluid, Oxygen Delivery 57. The definition DSHAC is adequate tissue perfusion, but many clinicians have incorrectly simplified it to inadequate TI oxygeny. Much of what we know about oxygen delivery and consumption started with a physiologist named Archibald V. Hill. He was an avid runner who measured the oxygen consumption of 4 tunnets running around an 88-track F in the process of his work. Hill defined the take, Oriquint, and det. He, a manly known for his work with on Meyer Hut, Bois unraveled the distinction between aerobic and anaerobic metabolism, for which they went awarded. The Nobel print in 1922. Blood delivers oxygen by red cells, which comment hemoglobin. The simple calculation of oxygen delivery due is the cardiac output CO multiplied by the content of oxygen carried by a volume AF blood cat. Doicocaine. The average hemoglobin molecule carries 134 milliliters of oxygen per tam, depending on the arterial hemoglobin HB Wigand saturation SAN of the red cell. In addition, a minor amount of oxygen is dissolved in platinum. This amount is calculated by multiplying the Subidayunstan 0.00 3 times the partial pressure of oxygen in the arterial blood PAB. The CAO, OD arterial blood is calculated as follows. CAO 1.34 HBS is 0003 PNE, where hemoglobin is in grams per deciliter. Cardiac output is heart rate, multiplied by the urologue volume. In a normal state, the stroke volume can be increased by alumning blood from one tissue. Fig 48, bag with side tube, Q on the left-hand side is U-white while rooting the Peist in the left hand from Hill Ave, Lupton, Florida, Mus. Ulmer exercise, lectic acin, and the Ontian station of C. Med 1923, 18,135 to 171. Med books in 58, section I, surgical basic principles. bed to the central vasculature, but most of the change in cardiac output is due to increased heart rate. In states of hemorrhage and resuscitation, the stroke volume is affected by infusion of fluids. As blood volume is decreased, it will ultimately affect stroke volume and is compensated by an increase in heart rate. Oxygen consumption, VO2 by cells, is calculated by subtracting the content of oxygen in the venous system, CVO2, from delivered oxygen content in the arterial blood, CaO2, VO2 equal to co-CO2, CVO2. After simplifying the terms and converting the units, the result is as follows. VO2 equal to Ko 1.34 HGB, HGB, SVO2. The most conventional method of sampling the venous oxygen content is by drawing blood from the most distal port of a pulmonary artery catheter. The sample is taken from the pulmonary artery because venous blood is mixed there from all parts of the body. Oxygen content in the inferior vena cava is typically higher than in the superior vena cava, which is higher than in the coronary sinus. The average mixed venous sample is 75% saturated. So the oxygen consumption is thought to be, on average, 25% of the oxygen delivered, figure 4.9. Thus, teleologically, there is ample reserve of oxygen delivered. With advancements in technology, catheters are now available that can continuously measure the venous saturation in the pulmonary artery. These use technology similar to the pulse oximeter built into the tip of a pulmonary artery catheter, which uses near-infrared, near-light waves to measure the oxygen saturation state of hemoglobin. These advanced catheters can also provide cardiac output continuously. In the past, cardiac output was inferred by measuring the rate of change in temperature in the heart at the distal aspect of a pulmonary artery catheter. By infusing a standard volume of iced or room temperature water into the proximal port and measuring the change in temperature. In recent years, pulmonary artery catheters are no longer commonly used. Venous oxygenation can still be measured from central lines, but these assessments are no longer mixed, venous in nature. Cardiac output and oxygen delivery are also affected by the end diastolic volume of the left ventricle. As described by Starling in 1915, cardiac output increases when the ventricular fibers increase in length. There is a maximum filling point then. Consumption, VO2, 600, 500, 40, 300, 200, 100. Normal sepsis hyperdynamic, 0, fig. Oxygen delivery due to and consumption VO2, 1000 ml, min of O2. The oxygen consumption in a min. At very low oxygen delivery, it is believed that there is oxygen debt during shock and during circulatory system is paying back its oxygen debt. 0, 50, 100, 100, and 50, 200, 200, and 50, 300, and 50, 400, 400, and 50, 500, uploaded by cardiac output no longer increases, figure 4.10. Left ventricular end diastolic LVED volume can be inferred by using a pulmonary artery catheter and measuring the wedge pressure, which represents preload. This reflects the pressure in the left ventricle because the vessels from the pulmonary artery to the left ventricle have no valves. Alternative approaches can help optimize the filling volume in the left ventricle. Pulmonary artery catheters for calculating the right ventricular end diastolic volume are available but are rarely used. Echocardiography using transthoracic or esophageal probes can directly estimate filling volumes in the heart. However, variations in volume, stroke output cardiac, LVID preload, FIG, 4.10 Starling curve, as left ventricular end diastolic LVE pressure is increased, the fibers of the heart muscle are lengthened, resulting in increased contraction and increased cardiac output. This occurs to a certain point, at which increases in volume and length do not result in increases in cardiac output. Oxygen debt. During normal states, oxygen delivery is approximately stated as 25% of delivery and is approximately 250 ml. Is delivery dependent and occurs in shock. And there is a hyperdynamic stage during which the 600, 650, 700, 700, and 50, 800, 850, 900, 950, delivery 1,000, 1,000, 150, 1,000, and 50, 1,000, 100, 1,200, medbooks VN, and heart size can distort results. Heart size is also affected by medical conditions that can stress and dilate the heart. The interpretation of heart size and adequate resuscitation data is thus subjective. Optimization, supernormalization. During the late 1980s, surgical critical care evolved into a specialty, focusing heavily on ventilator support and optimizing oxygen delivery to tissues. One of the pioneers of modern surgical critical care, William Shoemaker, theorized that during shock, because of a lack of oxygen delivery, there was anaerobic metabolism and an oxygen debt that needed to be repaid. He showed that after volume loading, if oxygen delivery increased, consumption would also increase until a certain point when an additional increase in oxygen delivery did not result in increased consumption. This increased oxygen consumption was thought to be the process of paying back the oxygen debt that occurred during ischemia throughout the body. Patients in shock were found to have a hyperdynamic stage in which increased oxygen delivery resulted in increased consumption. The assumption was that increased consumption was replenishing the oxygen debt that the body had incurred. Shoemaker popularized the concept of optimization or supernormalization of oxygen delivery, which means that oxygen delivery is maximized or increased until its consumption no longer increases, but instead levels off flow, independence. The optimization process involved administering a rapid bolus of fluid and confirming that it raised wedge pressure. Because the response to fluid infusion was dynamic, the infusion process had to occur during a short period, such as 20 minutes. If it took longer, changes in the vascular space and specifically the heart may be due to other variables in addition to the fluids used. Also, if the response was not measured immediately after infusion, the effect of the infusion was known to degrade quickly as fluids moved out of the vascular space. Wedge pressure and cardiac output must be measured minutes before fluid infusion to determine whether it is effective. If cardiac output increases with the wedge pressure increase, it is assumed that oxygen delivery increases. By sampling the central venous oxygen content when measuring cardiac output, clinicians can determine whether oxygen consumption also increases. This process was originally repeated until it was demonstrated that the fluid bolus did not increase cardiac output. The goal was to optimize oxygen delivery from the delivery-dependent portion of the curve to the portion that was not delivery-dependent, figure 4.9. The preferred fluid during the optimization process was LR solution, as it was inexpensive and thought to be innocuous. Once the Starling curve was optimized and that LVED volume could no longer be increased with increases in wedge pressure preload, wedge pressure would be kept at that maximal level. Further increases in wedge pressure without increasing LVED volume meant that patients might suffer from unnecessary pulmonary edema. Once fluid infusion maximized cardiac output and oxygen delivery, an inotropic agent would be added to further push cardiac output to a higher level. The agent recommended at that time was dobutamine. The dose was increased and its effect on cardiac output was documented. With each maneuver, oxygen consumption was measured and cardiac output optimized to meet the consumption demands. This optimizing process maximized oxygen delivery to ensure that all tissue beds were being fed adequately. Shoemaker's earlier clinical trials had shown that patients resuscitated in this manner had a lower incidence of multiple organ, uploaded by 4-shock electrolytes and fluid 59, dysfunction syndrome MODS and death. During this optimizing era, ARDS and MODS were the leading causes of late death in trauma patients. However, subsequent clinical studies failed to repeat Shoemaker's success. Randomized prospective trials showed that the optimization of oxygen delivery and consumption did not improve outcome. In general, patients who responded to the optimization process did well, but those who could not have their oxygen delivery augmented to a higher level did poorly. Thus, although response to optimization was prognostic of outcome, the process itself did not seem to change outcome. One of the reasons that the earlier study succeeded may have been because the control patients were not adequately resuscitated. With the later trials, when patients were adequately resuscitated, the optimization process did not improve outcome. In fact, the aggressive use of fluids to achieve supernormal oxygen delivery could cause increased multiple organ failure, abdominal compartment syndrome, and increased mortality from excessive crystalloid infusions. 31. Over time, the widely used pulmonary artery catheter fell out of favor. Studies have shown that the discontinued use of the pulmonary artery catheter has not adversely affected outcome. Due to the invasive nature of the pulmonary artery catheter and concern that the data derived from the catheter were often misinterpreted, its use has virtually disappeared from the modern-day surgical ICU, aside from the use in cardiac surgery patients. Moreover, oxygen delivery in hyperdynamic patients could not be driven to a point at which consumption seemed to level off. One theory was that as the heart was being pushed with the supernormalization process, the heart's metabolism increased such that it was the major organ seemingly consuming all of the excess oxygen being delivered. The harder the heart worked to deliver the oxygen, the more it had to use. Normal cardiac output for an average man is about 5 Lmin, yet patients were often driven to a cardiac output of 15 Lmin or more for days at a time. The critics of the optimization process asserted that there was a point during oxygen delivery when it was flow dependent, but the coupling of consumption and delivery made it seem like increased delivery was the factor that increased consumption. Furthermore, optimization advocates neglected the fact that the body was usually already at the flat part of the oxygen consumption curve. Rarely was oxygen delivered when it was critical or when the body was consuming all that was being delivered. The result of the optimization process usually meant that patients were flooded with fluids. The hyperdynamic response in MODS may have resulted from the fluids used, which may have caused an inflammatory response at excessive volumes. The concept of oxygen debt, introduced by the physiologist Archibald Hill almost 100 years ago, may have some vital flaws in it. His original work on aerobic and anaerobic metabolism in just 4 patients has now been propagated for a century. However, modern exercise physiology studies have shown that oxygen debt is repaid during a short period. It does not take days. In contrast, the optimization process showed oxygen debt for long periods. During massive hemorrhage, ischemia to some tissues is theoretically possible. However, in acute hemorrhage, when the BP falls to 40 milliminute of Hg, cardiac output and thus oxygen delivery are typically reduced by only 50%. Before resuscitation with the cellular fluids, the hemoglobin level does not fall significantly. In this state, oxygen delivery is cut by only half, and the body is designed to have plenty of reserves. Cells consume only 25% of the delivered oxygen in the normal state. Whether any ongoing anaerobic metabolism is actually occurring is questionable, as the oxygen. Medbooks VN, 60 section. Surgical basic principles. Delivery has to fall to 25% of baseline to theoretically be anaerobic. When resuscitation takes place without blood to restore the intravascular volume, the hemoglobin level theoretically may fall by 50%, but cardiac output is generally restored to the original state. Again, oxygen delivery is only half, with plenty of oxygen still being delivered to avoid ongoing anaerobic metabolism. It is difficult to reduce cardiac output and hemoglobin level to a level at which oxygen delivery is reduced by 75%, that is, to below the anaerobic threshold. In hypovolemic shock states, it was thought that even though global oxygen delivery may be adequate, regional hypoxia is ongoing. Different organs and tissue beds are not similar in their oxygen needs or consumption. Hypoxic insult may be experienced by the critical organs whose flow is usually preserved, whereas non-essential organs are sacrificed in terms of oxygen delivery. Yet such patients are not actively moving, and their oxygen demand is minimal. Thus, the theory of oxygen debt is in question. In exercise states, even if there is oxygen debt, it is paid back quickly and does not take days. To optimize oxygen delivery, one of the most efficient ways, according to past calculations, was to add hemoglobin. If the hemoglobin level increased from 8 to 10 grams DL by transfusing 2 units of blood, oxygen delivery would increase by 25%. Blood transfusions were part of the optimization process because they also increase wedge pressure and LV volume, and thus cardiac output. But it was rarely noted that transfusions placed patients on the flat part of the consumption curve, figure 4.9. Decades ago, it was also thought that an increased hematocrit would reduce flow into capillaries, so clinicians had reservations about transfusing too much blood. Studies in the 1950s demonstrated better flow at the capillary level with diluted blood. However, the small amount of decreased flow with the higher viscosity was in the range of a few percentage points and did not compare to the 25% increase in oxygen delivery with a transfusion of a couple of units of PRBCs. Blood transfusions by calculations would be the most efficient way of increasing oxygen delivery, if that were the goal. Current exercise physiology studies have shown that professional athletes perform better when their hemoglobin levels are above normal. The athletes who blood dope by undergoing autologous blood transfusions or by taking red cell production enhancers such as erythropoietin or testosterone are now banned for illegal performance enhancement. Such athletes have cardiac outputs of more than 20 to 50 Lmin. They do not seem to have any problems with blood sludging from the higher flow and more viscous blood than normal. The argument against this analogy of athletes and their capability to deliver oxygen despite a high hematocrit level is that injured patients have capillaries that are not vasodilated and are often plugged with white and red cells. Global perfusion versus regional perfusion gaining the ability to measure BP was revolutionary. However, because the main functions of the vascular system are to deliver needed nutrients and to carry out excreted substances from the cells, clinicians constantly ask whether BP or flow is more important. During sepsis, systemic vascular resistance is low. A malfunction somewhere in the autoregulatory system is assumed. A teleologic explanation, however, is possible. Lower systemic vascular resistance could be a way our body evolved so that cardiac output can be easily increased as afterload is reduced. Some shunting is believed to occur at the capillary level, however. An important question is, should BP be augmented with exogenous? Uploaded by administration of pressor agents normalizing BP at the expense of capillary flow. High doses of pressor agents most likely worsen flow because lactate levels rise if the pressor dose is too high. That rise in lactate levels could be caused by a stress response, as catecholamines are known to increase lactate levels. Or it could also be caused by decreased flow at the capillary bed. Purists would prefer to have lower pressure as long as flow is adequate, but some organs are somewhat sensitive to pressure. For example, the brain and kidneys are traditionally thought to be pressure dependent, however. When early experiments were done, it was difficult to isolate flow from pressure due to the interrelation of those two values. With the concept that flow might be more important than just pressure, technology developed a focus on measuring flow of nutrients rather than pressure. During hemorrhage or hypovolemia, blood is redirected to organs such as the brain, liver, heart, and kidneys at the expense of tissue beds such as the skin, muscle, and gut. Thus, the search ensued to find the consequences of this shunting process. The gastrointestinal GI tract became the focus of much of this research. Two main methods were developed: gastric tonometry and neurotechnology. Gastric tonometry measures the adequacy of blood flow in the GI tract through placement of a CO2 permeable balloon filled with saline in the stomach of a patient after gastric acid suppression. The balloon is left in contact with the mucosa of the stomach for 30 minutes, allowing the CO2 of the gastric mucosa to pass into the balloon and equilibrate. The saline and gas are then withdrawn from the balloon, and the partial pressure of the CO2 is measured. That value, in conjunction with the arterial HTO3, is used in the Henderson-Hasselbalch equation to calculate the pH of the gastric mucosa and, by inference, to determine the adequacy of blood flow to the splanchnic circulation. The logistic difficulties of gastric tonometry are concerning. Data on its use have suggested that even though it can help predict survival, resuscitating patients to an improved value had no survival benefit. Most clinicians have now abandoned gastric tonometry. A multi-center trial showed that in patients with septic shock, gastric tonometry was predictive of outcome. But implementing this technology was no better than using the cardiac index as a resuscitation goal. 2. Regional variables of organ dysfunction are thought to be better monitoring variables than global pressure-related hemodynamic variables. However, the data seem to consistently indicate that initial resuscitation of critically ill patients with shock does not require monitoring of regional variables. After stabilization, regional variables are, at best, merely predictors of outcome rather than goals that should be targeted. The optimal device for monitoring the adequacy of resuscitation should be non-invasive, simple, cheap, and portable. In-ear spectroscopy uses the NIR region of the electromagnetic spectrum from about 800 nanometers to 2,500 nanometers. Typical applications are wide-ranging: physics, astronomy, chemistry, pharmaceuticals, medical diagnostics, and food and agrochemical quality control. The main attraction of NIR is that light at those wavelengths can penetrate skin and bone. This is why your hand looks red when it is placed over a flashlight. The other visible light waves are absorbed or reflected, but red light and infrared light pass through skin and bone readily. A common device using NIR technology that has now become standard in the medical industry is the pulse oximeter. Using slightly different light waves, it yielded correlations with such variables as the cytochrome AAA3 status by adding a third light wave in the 800 nm region. When the oxygen supply is less than adequate, the medbooks begin. Rate of electron transport is reduced and oxidative phosphorylation decreases, leading ultimately to anaerobic metabolism. Optical devices that use NIR wavelengths can determine the redox potential of copper atoms on cytochrome AA3 and have been used to study intracellular oxidative processes non-invasively. Thus, with NIR technology, the metabolic rate of tissue can be directly determined to assess whether it is being adequately perfused. Animal models of hemorrhagic shock have validated the potential use of NIR technology in that they showed changes in regional tissue beds, figure 4.11. The superiority of NIR results over conventional measurements of shock has been shown in animal and human studies. To test the utility of this potentially ideal monitoring device, a multi-center prospective study was conducted to determine whether NIR technology could detect patients at risk of hemorrhagic shock and its sequelae. Performed in 7 Level 1 trauma centers, the study enrolled 383 patients who were in severe traumatic shock with hypotension and who required blood transfusions. A probe similar to a pulse oximeter was placed on the thenar muscle of patients' hands, continuously gathering NIR values. The NIR probe was found to be as sensitive as base deficit in predicting death and MODS in hypotensive trauma patients. The receiver operating characteristic curve shows that it also may be somewhat better than BP in predicting outcome. More importantly, the negative predictive value was 90%, figure 4.12. The non-invasive and continuous NIR probe was able to demonstrate perfusion status. Note, however, that MODS developed in only 50 patients in that study. This was probably because the method of resuscitating trauma patients changed during this period, and this reduced MODS and death rates. The changes that took place are discussed later in this chapter, but in brief, were due to damage control resuscitation. NIR technology may be able to show when a patient is in shock or even when a patient is doing well. Occult hypoperfusion can be detected or even ruled out reliably with NIR. In the trauma setting, a non-invasive method that can continuously detect trends in parameters such as regional oxygenation status, base deficit, or BP will surely find a role. Will this technology change how patients are treated? The debate now centers on this issue and raises some questions. Once a patient's hypoperfusion status has been determined, whether by BP, NIR technology, or some other device, what should we do with that information? Is it necessary to increase oxygen delivery to regional tissue beds that are inadequately oxygenated? Previous studies have shown that optimizing global oxygen delivery is not useful and that regional tissue monitoring with gastric tonometry has also failed to show benefit. So will NIR technology be helpful or harmful? An example of harm is over-resuscitating a patient to fix an abnormal value that may or may not be clinically relevant. The endpoint of resuscitation is constantly being debated. Since NIR results correlate well with base deficit, we may one day use NIR technology to infer the base deficit value indirectly. NIR technology has other promising uses in surgery, such as direct monitoring of flow and tissue oxygenation in high-risk patients, e.g. in those undergoing organ transplantation, for free flap perfusion, for classification of burn injuries, in intraoperative assessment of bowel ischemia with compartment syndrome, or even subdural and epidural hematomas. Or perhaps the most useful application will be in the ICU in septic shock patients at risk for multiple organ failure. Septic shock, in 2001, Rivers and colleagues reported that among patients with severe sepsis or septic shock in a single urban emergency department, mortality was significantly lower among those who were. Uploaded by Foreshock Electrolytes and Fluid 61, AA3 baseline, stomach change from baseline, AA3 from liver change percent baseline, AA3 kidney from change, AA3BASELINE, muscle from change, 180, 60, 40, 20, 0, 100, 80, 60, 40, 20, 0, 100, 80, 60, 40, 20, 0, 100, 80, 60, 40, 20 shock resuscitation, 0, 10, 10, 30, 50, 70, 90, time min, FIG, 4.1, 1 cytochrome AA, 3 measurements in rabbits during hemorrhagic shock. Shown are regional tissue beds and implied tissue oxygenation. Oxygenation at the mitochondrial level is preserved in kidney and liver compared with muscle and stomach. From P. Langdale, L. Moxie, and others near infrared spectroscopy, continuous measurement of cytochrome oxidation during hemorrhagic shock. Crit Care Med, 1997, 516, 170. Medbooks Evian, Section Surgical Basic Principles. ROC, curves for mode. Minimum systolic in the first, systole presso. 0.9 SCO, 0.8, 0.7, 0.6. Base deficit identity line, KES. 0.5, 0.4, 0.302, 0.1, 0.20204, 1. Fig 4.729, Nia Sportkoi and 383 Sion, who required blood manstatin, civilly and was to lay well with a stereo base saturation, predicts the development of TEMA 2007-12, 4-64. Table 4.5 SIRS criteria. Body temperature. Woe hepatory minor 000, less than M&M. 12 M40,000, 10%. SIRS systemic inflammatory Moore syndrome. Treated according to a U-hour protocol of Carly Gold. Directed that APR than among those who were given standard therapy 0.5% versus 46.5%. The premise was that usual care was not aggressive or timely early goal-directed therapy added this as it called for intravenous catheterization to manure central venous pressure and central oxygen saturation, which we use to guide the use of IV fluids, vanpremon, PRBC transfusion, and DUBA. Tamine to achieve prospecified physiologic rangier based on TH type of reach. The surviving SEP campaign clinical guidelines were initially published in 2004 and subsequently updated. In 2008, 2014, and 2016, the various methods of therapy WWW, graded by a panel of international experts. A randomized prospective study has now Shuashas protocol base care fairly PTI shock does not improve outcome. The newer Millie was not identical to the original Rivers Moody at the survival rates were much higher, but this Rudy may put show that the usual therapy may have already adopted many of the principles of early goal-directed therapy, and thus the difference intelligible. This study also found no significant benefit of the mandated use of central. Now's catheterization and central hemodynamic monitoring in all patterns, uploaded by maximum base deficit, minimum Masayo, min, upon arrival to E, 0.5, 0.8, 0.7, 0.8, 0.9, with traumatic furorephagic shul with hypoton evils in this then on knee. Is French SMS Nathans MFA gun function during traumatic shock mode. In the most recent update of the surviving sepsis CUMPAR clinical guidelines published in 2016, there was a majoration in the way that sepsis was defined previous iterations of the CAM. Pain SIRS criteria table 45 defines sepsis, in which the patient needed to have 2 out of 4 of the criteria present, and a source of infection to be deemed to have sepsis. This definition was fraught with problem as any non-infectious process that activated the inflammatory cascade could lead to a similar physiologic pit. Instead of using SIRS criteria, sepsis was now defined a increase in a patient's sequential organ failure armament SOFA, scared by 2 points from baseline table 4 since the SOFA, numbersome, so calendar at bedside and requires labyrinthi Remus Simples version was developed. The SOFA 4.7 can be calculanal at patient hodside by identifying tachy, PES, altered mental mata, and hypotension. If the patient missed 2 of the criteria and they are at risk for Segre, further work for an infectious source should be conducted. Problems with resuscitation. Lessons learned from the Korean War showed that resuscitation with blood and blood product was useful. Throughout that WA, the concept paled that a limited amount of salt and water should be given to patients after injuries. By the time of the Viet, watt volume resuscitation and excessive replacement of shed blood became an acceptable practice. That practice may have been influenced by studies of hemorrhagic shock performed by Tom Shines in his Dasic study. Shires used the Wiggers Mutal and lead 30 dogs to a man HP at 50 millimeters Hg for minutes. He then infused LR solution 5% AF body weight, followed by blood in 10 dogs, plumma 10 milliliters kg, followed by blood in another 10 dogs. Medbooks in and shed blood alone in the remaining 10 dogs. The dogs that. LR Lucian had the best survival, Yuri Shiras concluded. That, although the replacement of lump blood with whole blood E mains, The primary treatment of shock adjunctive replacement of the coexisting functional volume deficit in the interstitium with a balanced salsillation appears. The beneficial Shires concluded that resuscitation with LR solution should be initiated while whole. Blood transfusion are being mobilized. Soon the surgical community went from being judicious with crystalloid elutions to being aggressive. Surgoon, returning from the Vietnam War, advocated the use of crystalloids, a seemingly cheap and easy method of resuscitating patients. Touring that it saved lives, however. What evolved from this method of resuscitation was the so-called Da Nang Hung Aus, known as shock lung, and eventually ARDAS, as the U.S. Navy had in Field Hospital in Da Nang, Vietnam. The explanation for the evolution of the new condition was that Haddlefield patients were now living lang. To develop ARDS because their lives were assured with aggressive resuscitation and better critical care, including a great capability to rear renal failure. However, that explanation had no supporting evidence. The killed in action tape, the number of wounded patients who died before reaching a facility that had a surgeon, had not changed for more than a century. Table 4. Died af wounds rate, the number of wounded patients who died after watching a facility that had physician had decreased during World War II, thanks to the use of antibiotics, but it was slightly higher during the Vietnam War. The perceived reason for slightly higher died of wound rates was that patients in Vietnam were transported to medical facilities, much mazed publicly by Helmter's transpast times did indeed decrease from an average of 4 hours to 40 minutes. But if the sicker patients who would have normally died in the field were transported more quickly to lie in the medical facility, then the killed in action rate should have fallen, and it did not. Moreover, the renal failure rate and the cause of renal failure did not significantly change between the Korean War and the Vietnam War. Another file's argument was that the wounds SE dining the Vietnam War were where because of the enemy's high-velocity AK-47 rifles. Actually, the rounds AR bullets used by the AK-47 were similar to those used by the enemy in the Run Japanese War, World War I, and World War II, the 762 millimeters round. Undiniak rifle was invented by the Japaner in the early the pre-hospital system in the United States started to evolve. Previously, ambulances were usually knee. Table 4.5 sequential organ failure. System, liver, seminal nerve, 200, 2,150, 41 mashma, 15 to 10. Output, MIM. Percentage of in-spread gen map, man arterial pressure, pass, uploaded by shock, electrolytes, and fluid, driven by Mauritian. That is why the early ambulances had a stay ITA Eon wagon configuration. As the career path agency Modi-Cal technicians and paramedics grew, they started resuscitation in the FUD and continued it to the hospital in 1978. The FIT ATLS curse was given to prevent shock. The ATL's curse recommend that all trauma patients have 2 large bore IV lines placed, and I have 21 at LR Solution. The actual recommendation in the ATLSST specifically states that patients in cloth or shock should sign of LR Solution followed by blood products. How clinicians learned that crystalloid whooshings end innocuous and improve BP in hypotensive patient. In the 1980s and early 1990s, aggressive resuscitation was taught and indicted. The 2 large Bonfort lines started in the field. We converted to large IV lines, SHMU, a wire-guidal exchange system. Central venous lines were placed early for AGIV fluid resuscitation. In fact, some trauma center routinely perform cur-downs on the saphenous vein at the ankle to place 5V ruling directly in the wind and thereby zamy flow during. Resuscitation technology soon caught up and machines were built trapped, idly infused crystalloid solutions. The literature was filled with data showing the hematotimes resulted in disturbances of all types. Optimization of oxygen delivery was the goal. RAUL. Massive volumes of Crovolans were infused IMO patients. Table 4795 OFA, SAT PE 000, MNMH SOFA, sequential organifair assessum. Table 4.8 mortality rates, killed in action chet of wounds. Civil War, plus a JW 3811302012012010, 300 and 2,425. WW, Vimanui, SOFA, score. 10th score, 200 with 100 who? 20 to 53. Dopamine to 15A, OPEMPTY 01 of 5 to 5, 15 to 43, 500, 20 to 34, partat pressure of arterial Igini. Medbuxin, Min 1, 64 Section 1, surgical basic principles. Residents were encouraged to pound patients with fluids. If trauma patients did not develop ARDS, it was taught that the patients were not adequately resuscitated. But many clinical trials eventually showed that pre-hospital fluids did not improve outcome. Table 4.9. Bleeding, one of the most influential studies on hemorrhagic shock, was performed by Ken Maddox. And in 1994, the results were reported by Bickel and co-workers. 38. The aim of Maddox's study, a prospective clinical trial, was to determine whether withholding of pre-hospital fluids affected outcomes in hypotensive patients after a penetrating torso injury. IV lines were started in patients with penetrating torso trauma with BP lower than 90 mmHg Hg on alternating days. Patients received standard fluid therapy in the field or had fluids withheld until hemorrhage control was achieved. Withholding of pre-hospital fluids conferred a statistically significant survival advantage, a revolutionary counterintuitive finding that shocked surgeons. That 1994 article popularized the concept of permissive hypotension, that is, allowing hypotension during uncontrolled hemorrhage. The fundamental rationale for permissive hypotension was that restoration of BP with fluids would increase bleeding from uncontrolled sources. In fact, Cannon in 1918 had stated that inaccessible or uncontrolled sources of blood loss should not be treated with IV fluids until the time of surgical control. Animal studies have validated the idea of permissive hypotension. Burris and colleagues have shown that moderate resuscitation results in a better outcome compared with no resuscitation or aggressive resuscitation. In a swine model of uncontrolled hemorrhage, Sondine showed that raising BP with either fluids or pressors could lead to increased bleeding. The theory was that increasing BP would dislodge the clot that had formed. The study also found that the pressure that would cause rebleeding was a mean arterial pressure of 64.2 millimeters Hg, with a systolic pressure of 94.3 millimeters Hg and diastolic pressure of 45.2 imminent Hg. Other animal studies have confirmed these concepts. The next question was whether the continued strategy of permissive hypotension in the operating room would result in improved survival. Dutton and associates randomized one group of patients to Table 4, Pre-Hospital Fluid Studies in Trauma article, Abrahamian C., Thompson B.M., Town J.B., and others, the effect of a paramedic system on major open intra-abdominal vascular trauma. J. Trauma, 1983, 23, 687, 690. Koweski, S.M., Sise, M.J., Virgilio, R.W., the effect of pre-hospital fluids on survival in J. Trauma. 1990, 012, 1218. Bickle, W.H., Wall, M.J. Jr., Pepe, P.E., and others, immediate versus delayed fluid resuscitation patients with penetrating torso injuries. N. Engel J. Med, 1994, 111, 1109. Turner J., Nickel J., Weber L., and others, a randomized controlled trial of pre-hospital replacement therapy in serious trauma. Health Technol Assess, 2004, 157. Quanah First, Bun F., Roberts Hyde. Timing and volume of fluid administration for patients' trauma. Cochrane Database, Sys Reverend 2001, 1 CD 00 2245. Doula DJ, Wood GC, Raymer AR, and others' use of pre-hospital fluids in hypotensive blunt pre-hospital emerg care. 2002, 641, 420, 2002. Greaves I, Porter K&M, Revell MP, Fluid Resuscitation in Pre-Hospital Trauma Care, J.R. Cole, Serg Eden. 2002, 745, 457. Dutton RP, Mackenzie CF, Scalea TM, Hypotensive Resuscitation during Active On and Hospital Mortality, J Trauma. 2002, 211, 1146. Doula DJ, Wood GC, Radmer AR, and others' use of pre-hospital fluids in hypotensive blunt pre-hospital emerg care. 2002, 641, 420th. Uploaded by a target systolic BP of higher than 100 mmHg and another group to a target systolic BP of 70 mmHg. Fluid therapy was titrated until definitive hemorrhage control was achieved. However, despite attempts to maintain BP at 70 mmHg, the average BP was 100 mmHg in the low pressure group and 114 mmHg in the high pressure group. Patients' BP rose spontaneously. Titrating patients' BP to the low target was difficult, even with less use of fluids. The survival rate did not differ between the two groups. The idea of permissive hypotension was slow to catch on. The argument against allowing anything besides aggressive resuscitation was dismissed. Critics continued to emphasize that the Maddox trial focused only on penetrating injuries and should not be extrapolated to blunt trauma. Clinicians feared that patients with traumatic blunt head injuries would be harmed without a normalized BP. However, Shafi and Gentilello examined the National Trauma Data Bank and found that hypotension was an independent risk factor for death, but it did not increase the mortality rate in patients with TBIs any more than in patients without TBIs. The risk of death quadrupled in patients with hypotension. In both the TBI group odds ratio, 4.1, 95% confidence interval, 3.5, 4.9, and the non-TBI group odds ratio, 4.6, 95% confidence interval, 3.46. Furthermore, in 2006, Plurad and coworkers showed that emergency department hypotension was not an independent risk factor for acute renal dysfunction or failure. Trauma immunology and inflammation. The 1990s witnessed an explosion of information regarding alterations of homeostasis and cellular physiochemistry during shock. The scientific investigations of Shires, Carrico, Bao, and countless others shed light on the basic mechanisms underlying resuscitation of patients in shock. The pathophysiologic process has been identified as having an aberrant inflammatory status, resulting in the body's immune system damaging the endothelial tissues and ultimately the end organ. This inflammatory state leads to a spectrum of conditions, including fluid sequestration, which leads to edema and progresses to acute lung injury, systemic inflammatory response syndrome, ARDS, and MODS. Such conditions were in every surgical ICU. Attention focused on biochemical perturbations and altered mediators as sites for possible interventions. The fundamental cause, mortality of patients, For hypotensive fluid bleeding following patients, view impact patients. Summary of findings, paramedic system, open intra-abdominal vascular trauma, pre-hospital fluids trauma patients, pre-surgery fluids, hypotensive penetrating torso injuries, pre-hospital 1,309 serious trauma patients, pre-hospital bleeding trauma patients, pre-hospital hypotensive blunt trauma patients, pre-hospital a consensus view, pre-surgery fluids, hypotensive active hemorrhage, pre-hospital fluids, hypotensive patients. Medbooks VN was thought to be that ischemia and reperfusion, as shown in animal models, would create a state of damage to the capillary endothelium and subsequent changes to the end organ. It was generally accepted that the reason for the reperfusion injury was mediated by activated neutrophils that emitted deleterious cytokines and released free oxygen radicals. The animal models used to study these concepts were actually ischemia reperfusion models, in which the superior mesenteric artery that supplied blood to the intestines was clamped for a prolonged time before the clamp was removed. Later, it was thought that this was not an appropriate model to study hemorrhagic shock. It was found that there was a difference in pathophysiologic mechanisms between ischemia reperfusion injury and resuscitation injury. Death after traumatic injury was described as trimodal. Some patients died within a short time after injury. Some died in the hospital within a few hours, and many died late in the hospital course. However, a more recent trial in trauma patients has shown that deaths occur in a logarithmic decay fashion and follow the rule of biology. No grouping of deaths can be seen unless the data are represented or lumped together as immediate, early, or late. The only reason for the initial trimodal distribution was that patients who died after 24 hours were labeled under late deaths, 39, according to the traditional, although now discredited trimodal pattern. The patients who typically died first could be aided by a better pre-hospital system and, more important, by injury prevention. For the second group of patients, better resuscitation and hemorrhage control was thought to be a potentially life-saving intervention. For the third group, the late deaths, immunomodulation was considered to be key. The cause was thought to be the inflammatory adaptive aberrancy after successful resuscitation, when there's prolonged end arterial cessation of flow-producing tissue ischemia for a time, followed by reperfusion. It is termed reperfusion injury. For example, with an injury to the femoral artery that requires 4 to 6 hours for circulation to be restored, muscle cells undergo ischemia and reperfusion, in which the cells will start to swell, which can result in compartment syndrome in the lower leg. This ischemia and reperfusion were thought to occur after a period of hypotension. However, it is now known that the pathophysiologic change is due to resuscitation injury rather than to reperfusion injury. Rolling activation, L-selectin, chemokine, cytokine, L-selectin, P-selectin, E-selectin, Fig 4.1. 4 intravascular neutrophils that are causes firm adherence, and transendothelial migration. Our transmigration process injures the endothelium with fluid leaks out of the vascular system. ICAM, adhesion molecule, chemokines, uploaded by 4 shock, electrolytes, and fluid 65. With improved technology, the immunologic response after trauma was heavily researched. In the past, we were limited to studying physiology. A theory started to evolve that shock caused an aberrant inflammatory response that then needed to be modulated and suppressed. Many studies during this era showed that the inflammatory system was upregulated or activated after shock. The white cells in the blood became activated. Neutrophils were identified as the key mediators in the acute phase of shock, whereas lymphocytes are typically key players in chronic diseases, e.g. cancer and viral infections. Shock, caused by various mechanisms, was thought to induce ischemia to tissues and, after reperfusion, to set off an inflammatory response, which primarily affected the microcirculation and caused leaks, figure 4.13. Typically, neutrophils are rapidly transported through capillaries. However, when they are signaled by chemokines, neutrophils will start to roll, firmly adhere to the endothelium, and migrate out of the capillaries to find the body's foes and initiate healing. Early researchers thought that neutrophils would battle invaders, e.g. bacteria, through phagocytic activity and the release of oxygen-free radicals. This was thought to be the reason for the leak in the capillary system, figure 4.14. Since neutrophils can be primed to have an enhanced response, a massive search took place to identify causes of neutrophil priming and downregulation. The mechanism: hemorrhage, shock, ischemia, reperfusion, cytokines, oxygen, radicals, microcirculation, immune response, neutrophils, Fig 4.11. 3. Hemorrhage, causing neutrophil activation. Firm adhesion, transendothelial, migration. Beta-2 integrin CD18, injury will adhere and roll until another set of mechanisms of the vascular system occurs. It is believed that this release of an oxygen-free radical. This could result in adhesion molecules, PECAM, platelet endothelial cell, ICAM1, ICAM2, PECAM1, ICAM1, Medbooks VN. 66, Section 1, Surgical Basic Principles. Many cytokines targeted included interleukin types 1 through 18, tumor necrosis factor TNF, and adhesion molecules, such as intercellular adhesion molecules. Vascular cell